Welcome to the deep dive. Today, we're tackling a really fundamental area of the body's regulation, the thyroid and parathyroid glands.
Yes, absolutely.
You sent over some great information, and what strikes me immediately is that while they're right there together in the neck, and they both help keep calcium levels steady, their actual jobs day to day are pretty different.
That's a perfect way to put it. Yeah. They're like key players on the same team, maybe? Each with their own skills, but you need both for, balance.
Exactly. So our mission today is really to unpack their separate roles and then figure out how they manage to work together despite having different structures and, functions.
Sounds good. Let's do it.
Okay, let's dive straight into the thyroid first. Picture a sort of butterfly shape right there at the front of your windpipe. That's basically where the thyroid lives. It's one gland, but it's got the distinct shape, two main lobes joined by a little bridge, the isthmus.
Right, the isthmus.
Now, if we zoom way in, microscopically, the thyroid is made of these tiny sacs called follicles.
Follicles, yeah.
And inside them is this gel-like stuff, colloid. Think of that as the storage vault for the thyroid hormone.
It's where they keep the T3 and T4, essentially.
Got it. And then kind of tucked between these follicles, there are other parafollicular cells. We should probably keep those in mind. They've got their own job, too.
They definitely do. And it's inside those follicles, like you said, where the thyroid does its main thing, producing those key thyroid hormones, T3, which is triiodothyronine, and T4, thyroxine.
T3 and T4. Simple names for powerful hormones?
Exactly. And what's really interesting is that they absolutely need iodine, simple dietary iodine. Without enough of it, the thyroid just can't make these hormones. It's a crucial building block.
Right. Okay, so what do T3 and T4 actually do? Well, they're kind of the master controllers of our metabolism.
They really set the pace.
Yeah, they tell almost every cell in the body how fast to burn energy. They affect our body temperature, oxygen use, heart rate, even blood volume.
It's incredible, the scope.
Plus, they're involved in enzyme activity and how we break down carbs, fats, proteins, everything from our food.
And it's not just about energy. Their influence is huge. Thyroid hormones are absolutely vital for growth, for development, especially the reproductive system and the nervous system.
It really shows how these, relatively small molecules have such massive effects on just fundamental body processes.
Really does.
So, okay, T3 and T4 are made, stored in the colloid. How do they get out to work? When the body needs them, they get reabsorbed into the thyroid cells and then released into the blood.
But they don't travel alone, do they?
No, they hitch a ride on plasma proteins. And here's a key thing. The thyroid makes way more T4 than T3. T4 also sticks around in the blood longer.
It has a longer half-life.
Right. But T3 is the real workhorse, much more active. So the body's smart. It can convert that longer-lasting T4 into the more potent T3 right where it's needed.
Yeah, peripheral conversion. It's a very efficient system. And this whole process, making and releasing these hormones, it's controlled by this beautiful feedback loop. It involves the brain, specifically the hypothalamus, the pituitary gland just below it, and the thyroid itself. We call it the HPT axis, hypothalamic pituitary thyroid axis.
HPT axis, okay.
So the hypothalamus starts it off, releases TRH, thyrotropin-releasing hormone.
TRH.
TRH tells the anterior pituitary, hey, release TSH. That's thyroid-stimulating hormone.
Okay, so TSH travels to the thyroid.
Exactly. Goes through the blood, gets to the thyroid, and signals it to produce and release T3 and T4.
But it's a loop, like you said. It can't just keep going, right?
Right.
Because if those T3 and T4 levels get too high in the blood...
Then they talk back.
Yeah, they send a message back to the pituitary and the hypothalamus saying, okay, ease up on the TRH and TSH.
That's the negative feedback. Classic example, like a thermostat, just like you said earlier. When the temperature's right, the heater shuts off.
Right, keeps things in that healthy range. And understanding this three-way chat is so important because, a problem high up in the hypothalamus could look different on lab tests than a problem directly in the thyroid. It's not just about TSH being high or low. You need the whole picture.
Precisely. This whole system ensures the body has just the right amount of thyroid hormone for its needs. But what happens when it goes wrong, when this finely tuned system is off?
That's where we get thyroid dysfunction. Broadly, two main types. Hypothyroidism, not enough hormone, and hyperthyroidism, too much.
And these can affect anyone, really, any age group.
Let's dig into hypothyroidism first. That's when the body just doesn't have enough thyroid hormone to keep the metabolism running properly. Why might that happen?
Well, there's several reasons. Sometimes it's congenital, someone's born without a thyroid. or it didn't develop properly.
Okay.
We already mentioned iodine deficiency. If you don't get enough iodine, you can't make the hormone.
Right. The raw material.
Or the thyroid tissue itself might not be working right. Maybe a tumor or autoimmune diseases are very common causes, like Hashimoto's, where the body's immune system attacks the thyroid.
Autoimmune.
And the problem can even be higher up, back in that HPT axis we talked about.
Ah, right.
If the pituitary isn't making enough TSH or the hypothalamus isn't making enough TRH, the thyroid doesn't get the signal.
So the thyroid itself might be fine, but it's not being told what to do.
Exactly. Hypothyroidism is actually quite common, especially in women over 50 and older men too.
And the symptoms can be tricky, right? Because things like weight gain, fatigue, they're pretty vague.
Very vague. Yeah, they can easily be mistaken for just, getting older.
Yeah.
Which makes diagnosis sometimes a challenge.
And it's so crucial to catch congenital hypothyroidism in newborns. If a baby lacks thyroid hormone early on and it's not treated,
the consequences are serious. Poor growth, cognitive impairment. It really affects development.
That's why newborn screening is so standard and so important. Catching it early makes all the difference.
Absolutely. Then there's a more severe form in adults called myxedema.
Myxedema, okay.
It usually develops gradually as thyroid function gets worse and worse. Causes can be similar autoimmune, maybe a viral infection, sometimes overtreating hyperthyroidism or damage from surgery or radiation.
And it has a characteristic sign, right? This edema.
Yes, non-pitting edema.
Yeah.
So unlike typical swelling where you press it and it leaves a dent, this edema is firmer, it doesn't pit. It suggests a different kind of fluid buildup in the tissues, a real hallmark of severe hypothyroidism.
So treatment for hypothyroidism, it seems straightforward. We just need to replace what's missing.
Pretty much. The cornerstone is thyroid replacement hormone therapy. We give the body the thyroid hormone it needs to get levels back to normal and, well, get the metabolism running correctly again.
Okay, makes sense. Now let's flip to the other side. Hyperthyroidism. The thyroid's in overdrive. Too much hormone.
Right. Excessive production and release. And the most common cause here is Graves' disease.
Graves' disease. That's autoimmune too, isn't it?
Yes, it is. But instead of destroying the thyroid, the antibodies actually stimulate it, telling it to make more and more hormone. It basically pushes the accelerator.
Got it. And you mentioned goiter earlier, the enlarged thyroid. How does that fit in? It can happen in both hypo and hyper, right?
It can, yes.
Yeah.
And even with normal function sometimes. But it's often linked to hyperthyroidism. Or, paradoxically, it can happen in hypothyroidism too. If the thyroid isn't making enough hormone to tell the pituitary to back off TSH.
Ah, so the pituitary keeps yelling, make more hormone, by pumping out TSH.
Exactly. And that constant stimulation can make the thyroid gland itself grow larger, trying to compensate.
Okay, that clarifies the goiter link. So for hyperthyroidism, treatment aims to slow things down.
Right. Reduce the amount of circulating thyroid hormone. Options include surgery to remove part or all of the thyroid.
Okay.
Using radioactive iodine to selectively destroy thyroid tissue.
Right. We talked about iodine's role.
Or using medications. Drugs that either block hormone production or sometimes damage the gland. And of course, after many of these treatments, the person might actually need thyroid replacement therapy long term.
Because you've reduced or eliminated the source. Makes sense. This leads us nicely into the medications thyroid agents. You mentioned two main groups, thyroid hormones themselves and antithyroid drugs.
Exactly. And the antithyroids break down further into thiamides and iodine solutions.
Yeah.
So, yeah, replacement and suppression are the key strategies.
Let's start with the replacement hormones, used for hypothyroidism, obviously, but also sometimes to suppress TSH.
Yes. So, primary use is replacing low or absent hormone in hypothyroidism. But they can also suppress TSH overproduction in certain cases, like managing goiters or after thyroid cancer treatment.
What are the main options available?
Levothyroxine is the big one. It's synthetic T4, very consistent, most commonly prescribed.
Levothyroxine, okay.
Then there's desiccated thyroid that's from dried animal glands, contains both T3 and T4. It's more natural, some might say, but the T3-T4 ratio can be a bit unpredictable.
Right.
And liothyronine is synthetic T3, the more active form, used in specific situations.
So when we give these as meds, what do? Basically mimic our own hormones.
Precisely. They increase the metabolic rate, boost oxygen use, respiration, heart rate, help with growth and maturation, and affect how we handle fats, carbs, and proteins.
And the indications, hypothyroidism, myxedema coma, suppressing TSH, like we said, but also sometimes used with antithyroid drugs. That seems counterintuitive.
It does, but there are specific scenarios, like in thyroid storm, a severe hyperthyroid crisis. You might use them alongside antithyroids. or to prevent goiter during certain hyperthyroid treatments, and sometimes managing hyperthyroidism during pregnancy.
Interesting. But one thing you stressed, and it's vital, they are not for weight loss.
Absolute critical point. There's a specific warning against this. Using thyroid hormones for weight loss when your thyroid function is normal can really mess up your body's endocrine balance. It's dangerous.
Yeah, trying to override that tightly controlled HPT axis has consequences. It's not just about weight.
Exactly. It throws the whole system off.
Okay, so pharmacokinetics, how the body handles these replacement hormones. Absorbed from the gut, best on an empty stomach.
Yes, generally well absorbed, but food can interfere, so empty stomach is usually recommended. They bind to proteins to travel in the blood.
And T4 gets converted to T3 in tissues like the liver and kidneys.
Right, that peripheral conversion happens. Elimination is mostly through the kidneys, some in feces. And importantly for pregnancy, not much crosses the placenta, so it's generally safe, even necessary during pregnancy.
Good to know. But small amounts might get into breast milk?
Small amounts, yes. So caution is advised with breastfeeding.
Are there times when these hormones shouldn't be used or need extra care?
Definitely. Allergy, obviously. Acute thyrotoxicosis, that severe hyperthyroid state, unless you're also giving antithyroids. Acute heart attack, usually avoided unless the person already had hypothyroidism, because it can strain the heart.
Makes sense.
Caution, like we said, with breastfeeding, also in people with untreated adrenal problems. And older adults often need lower starting doses because they can be more sensitive.
What about side effects? If the dose is right, are there many?
Usually very few if the dose is correct. Sometimes skin reactions or temporary hair loss in kids early on. But if the dose is too high...
You get hyperthyroid symptoms.
Exactly. Anxiety, tremors, weight loss, palpitations, fast heart rate, chest pain, sweating.
So mimicking an overactive thyroid?
Right. Plus potential heart issues like arrhythmias or high blood pressure, CNS effects like trouble sleeping, headaches. Some people even report difficulty swallowing, which is why taking it with plenty of water is important.
Okay. And drug interactions. Need to take it away from food and other meds.
Yes, that empty stomach rule helps avoid absorption issues. Taking it 30-60 minutes before breakfast is common advice. It can also make the body more sensitive to catecholamines, things like adrenaline increasing arrhythmia risk. People with diabetes might need their insulin adjusted, digoxin levels might need watching, and it can boost the effect of blood thinners like warfarin, increasing bleeding risk.
So careful monitoring is key there.
Absolutely. The bottom line is, the prescriber needs a full list of all medications to check for interactions.
Got it. Okay, let's shift to the antithyroid agents. These are for hyperthyroidism, aiming to block hormone production. Two main types, thiamides and iodine solutions.
Right. Let's start with thiamides, methimazole and propylthyrosol, or PTU.
Methimazole and PTU. How do they work?
They work right inside the thyroid cells, stopping them from actually forming new thyroid hormone. So serum levels drop. They also slightly block that T4 to T3 conversion out of the body tissues.
So their main job is treating hyperthyroidism. How does the body handle them?
Pretty well absorbed orally. They tend to concentrate in the thyroid gland itself.
Makes sense. That's where they work.
PTU's onset and duration can vary a bit. Methimazole usually starts working in 30-40 minutes, peaks around an hour. Both are excreted in the urine.
Is there a difference in pregnancy or breastfeeding?
Yes, that's important. Methimazole crosses the placenta more easily and gets into breast milk in higher amounts than PTU.
So PTU might be preferred if an antithyroid is absolutely needed during pregnancy, especially early on.
Generally, yes. PTU has been preferred in the first trimester if treatment is essential, though risks still exist for the baby's thyroid. Methimazole might be used later, but overall they're ideally avoided in pregnancy.
And breastfeeding.
Also generally advised to avoid breastfeeding if taking them, because they can affect the baby's thyroid.
Okay. Any other major concerns or contraindications?
Allergy, of course. And there's a significant warning about PTU and liver toxicity, especially in children. It's really not a first-line drug for kids unless other options have failed or aren't suitable.
Liver toxicity with PTU noted. What about side effects in general?
Well, the most common is actually developing symptoms of hypothyroidism if the dose is too high or treatment goes on too long.
Right, the intended effect goes too far.
PTU, besides the liver issue, can cause nausea, vomiting, GI upset. Methimazole has less liver risk, but is more linked to bone marrow suppression affecting blood cell counts.
So blood tests are needed for methimazole?
Yes, regular monitoring of blood counts is important. Both can also cause rashes, sometimes hair loss.
Any key drug interactions with thiamides?
PTU can increase bleeding risk with anticoagulants like warfarin. And as the hyperthyroidism gets treated and the patient becomes euthyroid, normal thyroid function, how their body handles other drugs can change. Things like theophylline, beta blockers like metoprolol or propranolol, digoxin, their effects might alter, so doses might need adjusting.
Right, because the metabolic rate is changing.
Exactly.
Okay, now the other antithyroid group, iodine solutions. It seems odd that iodine, needed to make hormone, can also block it in high doses.
It is paradoxical, isn't it?
Yeah.
But yeah, high doses essentially flood the thyroid cells. They get oversaturated with iodine and just stop producing hormone. Sometimes it even destroys cells.
And this includes radioactive iodine.
Yes. Radioactive iodine, like I-131 or I-123, is taken up specifically by thyroid cells. The radiation then damages or destroys those cells. Low doses are used for scans, high doses for treatment.
So non-radioactive solutions like strong iodine or potassium iodide are used too.
Yes, less often now for long-term treatment,
Okay.
but they have roles, like short-term use before thyroid surgery or in thyroid storm or in radiation emergencies to protect the thyroid.
How does the body handle these?
Absorbed quickly from the gut, distribute widely, excreted in urine. The non-radioactive ones work fast, within 24 hours maybe, peak in 10-15 days, but the effect doesn't last very long. Sometimes they could even make a goiter worse long-term.
So limited use cases mainly, contraindications, pregnancy and breastfeeding again.
Absolutely. Detrimental to the fetus or infant, can cause hypothyroidism. Allergy to iodine is another contraindication.
Side effects, hypothyroidism seems likely.
Yes, that's a primary one. Also something called iodism, metallic taste, burning mouth, sore teeth, gums, cold symptoms, upset stomach.
Biodism, okay.
Can also stain teeth, cause rashes, and sometimes, paradoxically, make a goiter develop.
And drug interactions, similar to thiamides related to changing thyroid state.
Yes, monitor drugs like anticoagulants, theophylline, digoxin, beta blockers, closely as thyroid function changes. Also, eating lots of high iodine foods could increase toxicity risk, and taking other antithyroids might reduce how well radioactive iodine works.
Okay, that covers the thyroid agents thoroughly. So we've done the thyroid gland, its hormones, problems, and drugs. Now let's shift focus to its neighbors, the parathyroid glands. You said they also handle calcium. Where are they?
They're usually 4 tiny glands kind of tucked onto the back surface of the thyroid.
4 little glands, and their main job is calcium regulation.
Yes, their primary role is controlling serum calcium levels by producing parathyroid hormone, PTH.
Now, earlier we mentioned those parafollicular cells in the thyroid making calcitonin. How does calcitonin relate to PTH?
They're partners in balance, but they work opposite ways. PTH raises blood calcium when it's low. Calcitonin from the thyroid's parafollicular cells is released when calcium is high, and it works to lower it.
Ah, okay, so PTH raises calcium, calcitonin lowers it, a push-pull system.
Exactly. A counter-regulatory system to keep calcium in that tight normal range.
So, focusing on PTH, how does it raise calcium levels? What does it do?
It acts in several ways. 1, it tells osteoclast bone cells to break down bone and release calcium into the blood.
Okay, releases it from storage.
2, it boosts calcium absorption from food in our intestines. 3, it tells the kidneys to hang on to more calcium, reabsorb it, instead of letting it go in urine.
Reducing loss.
And 4, it stimulates the kidneys to make the active form of vitamin D, calcitriol. And active vitamin D is crucial for getting calcium absorbed in the gut.
Wow, so it hits calcium balance from multiple angles: bone, gut, kidney, vitamin D activation.
It's a comprehensive strategy.
Why is keeping calcium so tightly controlled so important anyway? What does calcium do?
Oh, it's critical for so many things. Moving stuff across cell membranes, nerve impulse transmission, muscle contraction, including the heart muscle blood clotting, just fundamental processes.
Right, so you need that level to be just right.
Precisely. And that's why you have PTH kicking in when levels drop and being suppressed when levels are high, with calcitonin doing the opposite when levels rise.
You also mentioned magnesium and phosphate playing roles.
Yes, magnesium levels can influence PTH secretion, both too high and too low. Magnesium can affect it. And high phosphate levels can indirectly stimulate the parathyroids.
How does that work?
Well, high phosphate tends to bind with calcium, lowering the free calcium levels in the blood. That drop in calcium then signals the parathyroids to release more PTH to compensate.
So it's all interconnected: PTH, calcitonin, calcium, phosphate, magnesium, a complex dance.
A very complex, finely tuned dance for calcium homeostasis.
So like the thyroid, the parathyroids can also have problems: too little or too much hormone.
Exactly. Hypoparathyroidism, not enough PTH, and hyperparathyroidism, too much PTH.
Let's start with hypo. Too little PTH means
Low calcium, hypocalcemia. And the most common reason for this is actually accidental damage or removal of the parathyroid glands during thyroid surgery. They're so close together.
Ah, makes sense. Treatment is then calcium and vitamin D?
Yes, replacing the calcium and boosting absorption with vitamin D therapy are the mainstays.
Okay. And the flip side, hyperparathyroidism. Too much PTH means.
High calcium.
Okay.
Hypercalcemia. This is often caused by tumors on the parathyroid glands, usually benign adenomas or sometimes genetic issues.
And high calcium causes symptoms.
It can. Fatigue, lethargy, personality changes, being really thirsty, urinating a lot, in severe cases, confusion, even coma. There's primary hyperparathyroidism, often in older women where the gland itself is the problem.
Okay.
And secondary hyperparathyroidism, often seen with chronic kidney failure, where the glands are overworking in response to another issue, like low calcium or high phosphate due to the kidney disease.
Right. You mentioned phosphate's role. High PTH often means low phosphate, too.
Yes. PTH causes the kidneys to excrete more phosphate, so levels often drop in primary hyperparathyroidism. The pseudorickets comment relates more to secondary hyperparathyroidism and kidney failure, where phosphate retention is the driver.
Got it. You also mentioned Paget's disease and postmenopausal osteoporosis. How do they fit in? Not parathyroid disorders directly?
Not directly, no, but they heavily involve calcium and bone metabolism, which PTH and calcitonin regulate. Paget's involves overactive osteoclasts, leading to weird, weak bone structure.
Okay.
Symptoms like bone pain, headaches, hearing loss can occur. Postmenopausal osteoporosis is mostly due to falling estrogen levels. Estrogen helps keep calcium in bones, so less estrogen means more bone loss, weaker bones.
So they're disorders of bone metabolism where calcium balance is a key factor.
Exactly. And the drugs used sometimes overlap or interact with the calcium regulating systems.
Which brings us to the parathyroid agents drugs affecting calcium levels. Antihypocalcemic for low calcium and antihypercalcemic for high calcium. Let's tackle antihypocalcemic first. For low calcium, often due to low PTH, vitamin D is key here for absorption.
Yes, vitamin D compounds are crucial. Available meds include teriparatide and parathyroid hormone itself, synthetic PTH basically. Calcitriol is synthetic active vitamin D. Abaloparatide is another related peptide.
How do these work?
Vitamin D forms like calcitriol boost calcium and phosphate absorption and influence bone. Teriparatide actually stimulates new bone formation, raises calcium, lowers phosphate. Parathyroid hormone is a simple replacement. Abaloparatide increases bone density.
And indications. Managing hypocalcemia in kidney dialysis or hypoparathyroidism?
Yes. And teriparatide is also used for some types of osteoporosis, postmenopausal, male hypogonatal, steroid-induced. Parathyroid hormone is just for hypoparathyroidism, calcium maintenance.
How are they given and handled by the body?
Calcitriol is oral, well absorbed, stored widely, lasts a few days, mainly fecal excretion. Teriparatide, parathyroid hormone, and abaloparatide are all daily subcutaneous injections.
Injections, okay.
They're absorbed quickly. Peak levels vary from minutes to a few hours. Half-lives are relatively short, around 1 to 3 hours depending on the drug. Metabolism often in the liver, excretion via kidneys.
Any major contraindications or cautions? Allergy, high calcium, vitamin D toxicities seem obvious.
Yes, those are key contraindications. Pregnancy only if benefit outweighs risk. Calcitriol generally avoided in breastfeeding due to risk of infant hypercalcemia. Caution with kidney stones.
What about that osteosarcoma risk mentioned?
Animal studies showed a potential increased risk of this bone cancer with teriparatide, abaloparatide, and parathyroid hormone. So caution in patients already at higher risk. They're often reserved for people not managed by just calcium vitamin D. Patients need to be informed.
And lifestyle advice. Calcium D intake, exercise.
Absolutely. Encourage adequate intake, weight-bearing exercise, reducing smoking and alcohol. Parathyroid hormone also has a restricted access program.
What about side effects for these anti-hypocalcemic agents?
GI effects are common: metallic taste, nausea, vomiting, dry mouth, constipation, poor appetite. CNS things like weakness, headache, drowsiness, irritability can happen, maybe from electrolyte shifts. Liver or kidney problems can increase drug levels and risk.
Yes.
And stopping suddenly might cause severe hypocalcemia, while starting PTH might initially cause hypercalcemia.
Interactions. Magnesium antacids are a problem.
Yes, avoid magnesium antacids due to risk of hypermagnesemia. Cholestyramine or mineral oil can reduce calcitriol absorption. And watch digoxin closely if calcium levels rise due to toxicity risk.
Okay, now the anti-hypercalcemic agents for high calcium, bisphosphonates and calcitonin salmon, they lower calcium but don't directly suppress PTH.
Correct. They act on the calcium levels themselves. Bisphosphonates like alendronate, radioactive, zoledronic acid slow down bone breakdown, bone resorption. This lowers serum calcium.
Without stopping normal bone formation.
Generally, yes. They target the resorption process.
And they're used for Paget's, postmenopausal osteoporosis, cancer-related hypercalcemia.
Yes, those are major uses. Zoledronic acid also for preventing fractures after hip fracture and for bone metastases.
How are they given and handled? Oral absorption isn't great.
Right, oral absorption is poor. No real metabolism, excreted by kidneys unchanged. Onset is slow, effects last days to weeks, even longer. Pamidronate and zoledronic acid, or 5E, also need dose adjustment in kidney problems.
Your cautions. Can't use if calcium is already low.
Correct. Contraindicated in hypocalcemia. Allergy too. Avoid in pregnancy generally. Caution with breastfeeding, kidney issues, upper GI disease, and those very specific dosing instructions for oral ones.
Right. Take with water, empty stomach, stay upright.
Yes. Crucial to reduce esophageal irritation risk. Zoledronic acid needs caution in aspirin-sensitive asthma.
His side effects. GI upset, bone pain.
Yes, abdominal pain, constipation, nausea, diarrhea, sometimes temporary increase in bone pain and Paget's. That esophageal ulceration risk with oral forms is real.
And the rare but serious ones, femur fractures, jaw necrosis.
Yes, long-term use over 5 years is linked to a small increased risk of atypical femoral fractures and osteonecrosis of the jaw. FARV forms have a risk of kidney toxicity.
Interactions. Antacids, calcium, iron interfere with oral absorption.
Yes, separate doses by at least 7 minutes. Risk of GI ulcers increases if taken with aspirin.
Okay, finally, calcitonin salmon. Synthetic version of the thyroid's calcium-lowering hormone.
Exactly. Available as injection or nasal spray.
And it works by inhibiting bone resorption and increasing calcium excretion by the kidneys?
Precisely. Lower serum calcium increases kidney output of phosphate, calcium, sodium.
Uses. Paget's. Postmenopausal osteoporosis, emergency hypercalcemia treatment.
Those are the main ones. Nasal spray is just for postmenopausal osteoporosis.
How's it handled? Absorbed well after injection.
Yes. Metabolized in tissues, excreted by kidneys. Crosses placenta. Animal data suggests effects on fetal weight. Inhibits lactation in animals, unknown in humans. Peak effect around 40 minutes. Duration 8-24 hours.
Contraindications. Allergy to salmon fish. Pregnancy lactation caution.
Yes. Allergy is key. Pregnancy only if benefit outweighs risk. Avoid in lactation due to calcium lowering. Caution in kidney dysfunction, pernicious anemia. And there's that potential link to malignancy with long-term use that needs evaluation.
Side effects. Flushing, rash, nausea.
Those are common. Flushing face hands, rash, nausea, vomiting, frequent urination, injection site inflammation.
Yeah.
Nasal spray can cause nasal irritation, often lessen over time.
Any interactions. Lithium levels might change.
Yes, calcitonin might lower lithium levels by increasing kidney clearance, so lithium doses might need adjustment.
Wow, okay. As we wrap up this deep dive on the thyroid and parathyroids, it's really clear how interconnected they are. Different hormones, but working together on metabolism and especially that crucial calcium balance.
Absolutely. And having a solid grasp of these systems, the hormones, the dysfunctions, and importantly, the drugs we use, is just fundamental for nurses. They see patients with these conditions all the time across the lifespan.
It really underscores how important it is to notice those sometimes subtle signs and symptoms, doesn't it? And also the huge role of patient education, making sure people understand their meds, why they take them, how to take them, what to watch for.
Couldn't agree more. Which leads to a final thought, maybe, for everyone listening.
Yeah.
How do lifestyle factors fit in? Things like diet, exercise. How might they impact thyroid and parathyroid health? And maybe even how well these medications work.
That's a great point. Something definitely worth considering in the bigger picture of endocrine health and patient care.